Ready?
Yeah, go ahead. Start it.
Okay. Good evening, everyone, and a warm welcome to all. It gives me a great pleasure to introduce our distinguished guest today, Dr. SUKALYAN, a leading neurointerventionist and pioneer in the field of neurointerventional and endovascular neurosurgery in Eastern India. Dr. Purkayastha is currently attached to the Institute of Neurosciences, Kolkata, where he continues to advance groundbreaking treatments and innovations in neurological care. His expertise spans a wide spectrum of life-saving procedures, including endovascular treatment of stroke, cerebral aneurysm coiling, AVM and brain fistula embolization, spinal vascular malformation treatment, and carotid intracranial stenting. Beyond the brain and spine, he is equally skilled in peripheral vascular interventions such as uterine fibroid embolizations and angioplasty for kidney and leg arteries, among others. With numerous national and international publications to his credit, Dr. Purkayastha embodies both medical excellence and compassionate care. We are privileged this evening to have him with us to share his insights on topic, Don't Be the 1 in 4, Stroke Insight. Over to you, Dr. Purkayastha.
Good evening, and thank you very much, sir, for the kind introduction. Actually, when you are telling me that you graduated in 1968, sorry, you passed the school in 1968, then I could understand. 66, and I could understand my position. I was born in 1972.
Okay.
So my regards to all of you, and thank you so much for taking out your valuable time for this session and having me here.
Sorry, that's the year some of us graduated.
Okay. Nice. And I am actually in this city of Calcutta since 2016, and from 2016, yeah. And initially, I was working in AMRI hospital, and then shifted to Institute of Neurosciences, Kolkata. So you can hear me clearly?
Yeah, you're audible.
Okay. And this will be a very informal discussion. And as I said, like, you can stop me anytime and we can have a nice discussion what we are talking about. So I'll be coming to the title once we discuss a little bit about and understand what is stroke. And I'm sure all of you know what is stroke, and you also know the basics, what you have to see when you think that the patient might be, or somebody of your near and dear ones might be having a stroke, so that you know what you have to do at that point of time. But we will just be recapitulating it in a very informal way and in a very basic way. So I'm really sorry about this technical glitch, because my computer doesn't go for the I can't show you as a slide show mode. But what when I talk about the stroke, that in the general population, they think that the stroke is heart attack. But we know that the heart attack is something called myocardial infarction, and the stroke is brain attack, because the very name stroke means a very sudden onset, some neurological deficit, and that is stroke. So obviously this is a brain attack and not the heart attack. And fundamentally, all these two terms, although it means that it affects two different organs, but these two organs are very intimately are related, because if heart doesn't pump blood to the brain cannot sustain for a long time. And if we see the other organ system in our body, the brain takes the largest amount of oxygen and glucose to sustain itself, because it's constantly working. If you want or not, it's constantly working. Even in sleep also it's working. So that's a very important organ, and that obviously we know that that differentiates us from other species, vertebrates. So as I said, the stroke is a sudden onset of neurological deficit. So what are the types of stroke? There are two types of stroke. And how does the stroke happen? Obviously, as I say, the stroke is related to the involvement of the blood vessel itself. So either the blood vessel has to get blocked, that causes a type of stroke, or the blood vessel ruptures, that causes another type of stroke. So the symptom of stroke, what we discuss in the definition of stroke, that may be a little bit different in two different types of stroke, but fundamentally, what the either it's ischemic or it's hemorrhagic, it causes some sort of a neurological deficit. And brain, as we see, it's an amazing organ, and it has two halves which are quite identical. When we see in the CT scan or an MR scan, we cannot differentiate the right or the left half differentially, but just by seeing the organ. But each area of the brain has been assigned to a very different kind of an work. So if we are a right-handed person, most likely our speech is located on the left side. And if you are a left-handed person, most likely the speech might be located on the right side. So, and the right half of our body is represented on the left side of the brain, and the left side of our body is represented on the right side of the brain. So it's a crisscross kind of arrangement. Up to a point, and beyond that, it's again each side represents the same side of the body, and that is quite down in the area we call this medulla in the brain. But when the stroke hits us, it usually hits a large part of the brain, which what we see is in the upper areas of the brain. And what we call ischemic stroke is basically means a tiny blood vessel is getting blocked by a thrombus or a clot which is inside the artery itself. So I'll come to the point where this clot can arise or how it propagates into the distal arterial system. But ischemic stroke basically means that a tiny clot which is blocking the artery. And when an artery gets blocked, that part of the brain which is supplied by that arterial twig does not get oxygen and glucose, and it stops working. And the symptom is represented in that particular part of the body, which has been represented by that tiny areas of the brain, and we get the symptom. Now, on the contrary, if the blood vessel ruptures or it leaks, there are various reasons for that. The most common being a very high blood pressure, and the blood, it comes out from the arterial system and it spills into the substance of the brain, or we call it brain parenchyma, and that what we call is called hemorrhagic stroke. But in layman's term, when I talk to the patient, or sometimes they come to me or come to us and say, "Je mathaye clot hoye geche." So they probably essentially means the hemorrhagic stroke. That's what it is. But clot inside the artery causes ischemic stroke. Clot outside the artery by a rupture or leak from the artery causes hemorrhagic stroke. So obviously, it is happening all on a sudden. So the signs and symptoms it causes, it's also devastating. But why we are not that much aware of the signs and symptoms of the stroke and as compared to heart attack? Because normally it doesn't cause so much of pain, except the hemorrhagic stroke where the pain comes. But in ischemic stroke, which is around 85% of the total amount of the stroke or the total stroke, do not cause any pain. It causes a painless, sudden deficit. So I will come to the slides where I will describe what deficits can happen in each areas of the brain. But in hemorrhagic stroke, the patient suddenly experiences excruciating headache, which he or she describes as the worst headache of my life. And along with that, they can have vomiting, loss of consciousness, depending on the size and the site of the bleed. So, that's how we understand that, well, the patient can be having a ischemic stroke where only the neurological deficit comes out as an, exogenous symptom. But when the patient experiences pain and vomiting, then most likely we are dealing with hemorrhagic stroke along with the deficit. Now, why the stroke is so important? Now, in my discussion today, I will be limiting myself mainly to the ischemic stroke. We can ask a couple of questions, and we can discuss also the hemorrhagic stroke. But normally, the term stroke in a general kind of population, they mean what is called an ischemic stroke, because 85% of the stroke is being ischemic stroke. Now, in this ischemic stroke, we always call time is brain. Why the time is brain? Because each second or each minute or each hour we lose after the patient gets a stroke without getting treated, a huge number of neurons are being lost. So again, I'm sorry because this font is very small here, but I will explain. So each second when an artery is getting blocked, around 32,000 neurons are getting lost each second, which comes to around 1.9 million every minute. And then every hour, 120 million neurons are getting lost permanently, and they die. So when they die completely, their work, they lose the capability of working in future. And as the time passes, the size of the stroke becomes bigger, and we tend to lose more and more number of neurons. But if we translate in our total age what we should have got without that stroke, the impact is quite huge. Like every minute, if someone loses 1.9 or 2 billion neurons, that means he is losing almost 3 weeks of his lifetime. So that much of time is getting deducted from his whole life. So that's quite bad. But at the same time, when the stroke becomes a big one, the amount of deficit becomes more, and there is very less likelihood the patient will retain back his or her capacity to work with those organs. That also comes down. So earlier we treat after the onset of stroke, the better will be the outcome. So that's why it is called the time is brain. Now, what is the burden of stroke? Now, as this year actually, when we celebrated World Stroke Day in 9th of November, yes, the tagline was "Every minute counts." Why? Because as I have already discussed with you that with each passing minute we lose a lot of neurons, and the chances of coming back to normal becomes remote. Now the statistics is again quite devastating. That from the statistics what we got now, the stroke is becoming second. It has come to the second place where in terms of the death and disability after heart attack. Now it was on the third place before before, and the second place was uh, the cancer and also the accidents and other things. But nowadays, because, and especially in India, where the amount of diabetes, obesity, and other stroke risk factors are going so high that the India is becoming, and of course, because by the grace of its large population size, the amount of stroke is becoming a huge burden every day. And in India, we have almost 1.8 million strokes every year. That essentially means around 5,000 stroke every day. And if we see the world statistics, it's around 13 million stroke happens every year and 5.5 million of death, uh, which happens every day. So if we see that the amount of death every year, it's very high. It's and more devastating than what we have seen in COVID. So, and because we are used to that kind of death rate from the stroke, and it is spread across the whole year, we are not much bothered about it. Now, in India, the infrastructure and the centers where we can treat stroke are very, very less actually. And that's why the amount of the burden, the social burden, or the burden to the government institutions or to the family, for that matter, is very, very high, especially in the rural areas. But unfortunately, the amount of stroke what we see and what the statistics says is more in uh, in in urban areas as compared to the rural area. If we see in West Bengal, how many stroke ready centers, we call the stroke ready centers, where the patient, when comes with a stroke, can be treated without any compromise, are very few. Uh, Not, unfortunately, not a very good setup has could have been established in the government institutions, and that's why there is so much of patients are being deprived every day who comes with stroke. Now, how to identify stroke? Obviously, we have to just remember this very simple mnemonic called "Be Fast." Be fast is very easy to remember. Now, what is B? B is the balance. That is, suddenly I'm, toppling down, or I'm losing balance, and I'm feeling dizzy. So that can be a sign and symptoms of stroke. But not all the cases of loss of balance or little bit dizzy is stroke. Obviously not, because there are many other causes like simple infection of the ear or some simple rhinitis, and cough and cold can make someone feeling a little bit dizzy. But without any other issues in the body, and without such history in the past, and if suddenly this is happening, obviously we have to keep stroke in our mind. And usually this happens when the back part of the brain is involved, not the front part. So we call it a sign and symptom of posterior circulation stroke. Posterior circulation means the arteries which are situated on the back areas of the brain. Now, in this context, I'm just telling that there are four arteries which reaches brain from heart, and which supply with oxygen and glucose. And so there are two front arteries called internal carotid artery, and there are two back arteries which are called vertebral arteries. So the balance problem usually comes from the affection of the vertebral arteries. Now, the second is the eye symptom. It can be a blurred vision, or it can be a transient loss of vision. Okay, so again, it can be both anterior and posterior circulation problems. But this is a very important symptom that we must not ignore, and it can be a telltale sign of a larger stroke which is coming, or which is maybe in larger stroke in making. Now, the fourth one is phase, that is sudden onset of drooping of one side of face or facial deviation uh, in one side, so which is obviously a very important symptom of stroke. Then obviously A is arm or leg weakness. Suddenly someone is experiencing some weakness or tingling or numbness in the leg or in arm. Then comes speech, difficulty in speech or slurring of speech, along with facial deviation, along with arms and leg weakness. Obviously, you are dealing with stroke. And once you get these symptoms, obviously it's time to call the emergency number, which is obviously is different in different countries. And that T also essentially means that you should not be wasting any time. So this is a very simple way of identifying that whether ischemic stroke is affecting somebody or not. And along with these, be fast if someone is also experiencing some sort of a headache or a little bit of vomiting or some kind of a nausea, then we should think that the person might be having a hemorrhagic stroke, which is around 15% of the total amount of stroke. Now, having said that, I just have kept one small video for you.
Starting in the United University, going out, having.
Now you can see that this guy he was walking in a mall, and suddenly you can just see his face, and his left arm is weak. His entire left side of the body is becoming weak, and he's not able to keep his balance, and he is falling down on the ground. And now if you see carefully his face was also getting deviated to one side. So obviously this is a clear sign and symptom of stroke. And now you being a responsible man standing nearby, you should come and ask him that what's your name, very simple question, or where do you stay? And you can see that whether his face is deviated to one side. And obviously, you can see that he will not be able to speak clearly. His speech will be slurred. Then you can just take both the arms and you just hold and lift your the arms, or you just keep your arms. So now, see his left arm is falling down. That means this is weak. So this 1 or 2 or maximum, 10 seconds of examination is what is needed to identify if the patient is having a stroke or not. And then you do not waste any time. So this guy is calling emergency number. So this is a very important way of identifying stroke, and it can really save someone's life. Now, what next? When the patient is at home, sometimes they call me that, the doctor, we are coming with a stroke and I've given a sorbitrate or an aspirin for that matter, or someone gives some gas medicine. Please don't try that, because he is not able to swallow. And if you try and force him to swallow with, little bit of sip of water, then he might aspirate, and you are making the problem even worse. So just check the blood sugar and blood pressure when the patient is in the hospital, or maybe someone is calling for an ambulance. And in many of our houses we have a small instrument for checking the sugar and BP. You please check whether the BP is shooting very high, because both in ischemic stroke or in hemorrhagic stroke, transiently the BP will go high. Please don't give any medicine to bring down the BP, because this might be a corrective phenomena which your body is trying to make some blood go to the brain through some other vessels when the main vessel is blocked. So this can be a repairing mechanism. Obviously, you check sugar, especially in diabetics, because sometimes very low sugar can mimic a stroke. Now, keep the medication list of the patient handy when for you to show to the doctor in emergency when you are taking the patient to some hospital, because this is very important. Because sometimes the patient takes blood thinners, sometimes the patient takes anticoagulant, which is also another kind of a blood thinner. And if these medicines are going on, our next step of thrombolizing or doing some other kind of putting the patient on some other kind of medication, the medication might vary. So do not wait for your family physician to drop in. Please call an ambulance, because many a time what we see, the patient is being taken. Patient was waiting for the family physician to come. He will come. He may or may not understand that the patient is having stroke. He will give some medicine, or he or she might advise to take the patient to a nearby nursing home, where again the time is lost. And when some senior doctor comes to that particular nursing home, he says, oh, the patient is having a stroke, so you take him to a bigger stroke ready hospital. So that's why it is so important that all of us should identify if the patient is having a stroke or not. So come to the hospital right away, a stroke ready hospital. So that information is very important, that in which stroke ready hospital, which is a stroke ready hospital in your vicinity, or which is the nearest stroke ready hospital in your area. So please Google that, and God forbid this should not happen to any one of us, but the information might be essential, and it might help somebody. So now, as I said, that every minute counts, and in each minute we are losing 2 million brain cells if we are not treating the patient in time. Now here, actually, this one is I'm sorry again, because this was a cartoon which will be nicely seen when we are in the slideshow mode. But again, I'm trying to explain this. Now, what is the concept of core and penumbra? Now, when an artery gets blocked, the centralmost part of the brain, which is supplied by the artery, is called the core. And some in and around the core, or we call the periphery, or the peripheral part of that particular supplying artery, we call it penumbra, because the peripheral part, one part overlaps the other. So here comes the trick of the blood pressure. So when there is a stroke, there is a reflux. So the brain tells your heart, okay, come on, increase the blood pressure, because one of my artery is blocked. So please increase the blood pressure so that the nearby arteries can come to help me, the area where it is blocked. So that's why the blood pressure increases, and the peripheral area of the brain, they try to sustain in that low pressure system. But that is not sustainable for a long time. That is not sustainable for a long time. So that's why the earlier the patient reaches hospital, and the earlier we can recanalize the artery, the better chances that your core remains very, very small. Because once the core is damaged, it takes only 3 minutes to the core area of the cells to die. And once it dies, it doesn't come back. So the brain has a very important mechanism called neuroplasticity. That means it has got the power of taking the work of the nearby areas, and it happens over time with medicine and physiotherapy. So with physiotherapy, you are indirectly telling the brain that the area which has been devitalized, the surrounding normal area, please take his work and just try to, come out with a better performance. So that's called neuroplasticity. So once we have treated the patient in an at the earliest, the core remains small and the whole penumbra is the one which we can save. So that is the crux of, or the bottom line of the strategies of the stroke treatment. And if the patient is left untreated, the whole penumbra, it goes for a toss, and eventually the whole large area of the brain dies, and the patient is left with a huge, large deficit. Now, what really happens in emergency department of a hospital? So when we take the patient, the doctor usually asks very simple questions there. Was the patient taking any blood sugar medication? Was he taking any blood pressure medication? And does he have any other signs and symptoms which has happened in the past? So these are a couple of questions they will ask you, and they will have a very quick kind of an examination, what I have already shown, and they will come up with a sort of a scoring called NIHSS scoring, that is National Institute of Health stroke score. And the larger the score, the patient will not do good. So that's what it is. So, but that is left to the doctors. So what investigation they will do? They will do just a CT scan, nothing else. So with a CT scan, we will understand whether the patient is having a stroke, which type of stroke, ischemic stroke or hemorrhagic stroke. Sometimes obviously some doctor will prefer MR scan, but MR scans are not available throughout 24/7 in all the hospital. So CT scan is the most important scan which has been widely used, and all our the current protocols what we use are based on the CT scan. So we do a CT scan and we identify whether this is ischemic stroke and whether this is hemorrhagic stroke, because the treatment is entirely different in these two types of stroke. Now, once we find that the patient is having an ischemic stroke, then we also need to know which artery is blocked. Okay. Now, in the CT scan, we are only seeing the tissues. We are not seeing the arteries. So what we have to do is we have to go for an angiogram, and that is a CT angiogram. So the CT scan and the CT angiogram, it doesn't take more than 10 minutes. In a good center, it should not be taking more than 10 minutes. So when a patient arrives in the ER, it takes around 5 minutes to take the history from the relatives. And in these 5 minutes, another doctor is examining the patient, coming to a conclusion that the patient is having a stroke, shifting the patient to a CT scan, doing the CT and the CT angio in 10 minutes. So it takes around 15 minutes. So this 10 to 15 minutes, what we call door to needle time. Door to needle time. That means within these 15 minutes, we must identify that the patient is having a stroke, patient is having an ischemic stroke, and we also identify, which artery is blocked. So now comes the time when the patient is reaching the hospital. Now, if the patient reaches within 4.5 hours of the onset of stroke, that means the last seen well. Last seen well. If the patient is a wake-up stroke, that means the patient is waking up from sleep and he's having the signs and symptoms of stroke, then the last seen well has to be when he went to sleep or when he went to bed. So obviously that will be more. So here now please remember that if the patient is coming within 4.5 hours of stroke, then the first thing in acute ischemic stroke, we inject a drug called TPA, tissue plasminogen activator. And that is the life-saving intravenous drug what we give in ER, and that should be given within 15 minutes, and that should be the door to needle time in a good stroke ready hospital. In Western countries, unfortunately, because of the traffic, because of other issues, we see a huge chunk of the patient that do not reach on time, and also and adding to that, some patients do not reach the time because someone has misguided them, has put them to some other hospital, or the family physician probably has not guided them to a stroke ready hospital. Now, to circumvent these issues, we are coming out with some hub and spoke model with tying up with some peripheral centers and teaching them how to identify stroke. And if they find a stroke, you may not do a CT angiogram, just do a CT scan and exclude other causes of stroke. Just pushing that medicine is no harm, but it may save someone's life. So that drug is only possible, when the patient comes to ER within 4.5 hours. But if the patient is coming more, after that time period, this is not indicated at this point of time worldwide. Initially, this time was around 3 hours. Now this has been extended to 4.5. Now, after that time, what is the treatment then? Now, initially, that treatment, which is obviously an endovascular or surgical, because no other drug is available. So, with the CT angiogram, we have identified that there is a vessel occlusion. Now, if it's a very tiny vessel, then obviously this will be translated to a patient signs and symptoms. So obviously the patient signs and symptoms will be not that, the deficit will not that be big. So normally with medicine, they can recover with a very tiny stroke. And if the patient is not even coming within 4.5, it's very well if the patient comes within 4.5, you give injection, the patient will recover completely. But if the patient is not coming within 4.5 hours and it's a very tiny distal vessel, so obviously in a very tiny vessel, you cannot take the clot out from a very tiny distal vessel. But with medicine, what we have seen, the patient recovers completely. But if a large clot is blocking a major artery, then what happens? Then our literature says that this injection, if the patient is coming within 4.5, also this injection do not lyse the bigger clots. That is again a problem. So if a clot is a large one, that is we call a major vessel occlusion. Major vessel occlusion. So if there's a major vessel occlusion, then we give this medicine, but we do not wait the drug to work and we see some kind of recovery in the patients. No. Directly we take the patient to cath lab and we do a test called DSA, digital subtraction angiogram. That is the same kind of an angiogram the cardiologists do when the patient gets a heart attack. So we puncture the groin of the patient and we go and take the clot out. Now I'll just show you a small video. So this is actually the beautiful arterial system of our brain. You can see that they are quite identical, and the right side is almost more or less similar to the left side. With the left side. Now, if there is a major vessel occlusion, so what happens? Now, this is a CT scan. The CT scan. The CT scan shows that this arrow is a tiny clot, white clot is sitting in the artery, and this is a DSA picture. Now we see that if we refer the previous slide, this artery is having so beautiful branches on both the sides, as you can see here. But in this one, this part is blocked here. We can see the branches here, but this part is completely blocked. Now, this is a large vessel occlusion. This is what is called a major vessel occlusion. Now, with this major vessel occlusion, there is a very low likelihood the patient will become better with simple TPA injection. Then obviously we need to take that clot out from the brain artery. So this is the picture before the surgery, and this is the picture after the surgery. As you can see here, that the clot has been extracted from this part of the artery, and we can see now the whole artery is filling, and you will see magically the patient recovers on the table. He or she was not able to speak or not, because this is on the right side. So obviously there will be a little bit of slurred speech, and his upper and lower limb will be weak. And on the table, the patient will start lifting his hand and moving his leg, and his speech will become better. That is the kind of the result you can get. In our medical field, there is something called NNT, number needed to treat. I'm just explaining you here. This might be interesting for you. Number needed to treat. What is that number needed to treat means? That means when we administer drug to a particular, to some patient, all the patients may not become better with that drug. Like many of us, we take statins, that means which reduces the cholesterol level with the aim to reduce stroke or heart attack. But the number needed to treat for these statins is around 50. That means if we take 50 patients who are taking the statins, in one patient, they will get the benefit of preventing heart attack or stroke. In the rest 49 patients, it will not happen. So that is the beauty of number needed to treat concept. Now, in this mechanical thrombectomy, the procedure, what we call taking out the clot from the brain, we call it mechanical thrombectomy. The number needed to treat is 2 or 3. That means if you treat 2 patients, 1 patient will completely recover, and that can be the highest amount of medical or scientific evidence in a treatment can have, medical treatment can have. Because number needed to treat, if it is 1 in 2 or 1 in 3, that means the efficacy of the treatment is extremely high. Now, how do we do that? So we take the patient to cath lab, and we puncture the groin, and I'm just showing you the cartoon. There are many devices nowadays. There are suction device, there are stents. We put the patient in. We take these devices inside, and this all been done in cath lab, or we call catheterization laboratory. There's a huge X-ray machine through which we go inside, and from the groin artery we reach the brain artery in just 5-10 minutes, and we deploy those stent across the clot, and we take the clot out, or extract the clot out, or we suck the clot out. So this is a video. Just one sec on this. Yeah. So this is the video. As you can see, these are the arteries of the brain, and we put a tube here, catheter. We take a wire, and this is the clot, which is sitting in a major artery. So we cross this clot with a wire, and over the wire, we take a tiny tube called microcatheter. So this is a very tiny tube. This is actually 1.5 French or 1.7 French. That means 3 French is equal to 1 millimeter. So that's the kind of small diameter, small bore, and we take it across. And now we take the stent. We have taken the wire out. Now we are taking the stent inside that tube, and we will take this tube out little bit so that the stent is deployed. across. Now we are taking the tube out, the stent is deployed. Now, immediately the stent will press the clot against the wall and the circulation is re-established. So within no time, the area of the brain who was, stubbing for oxygen and glucose gets the blood supply. So we wait for some time, and now we take the whole system out, and then the stent pinches the clot and taking out and put it inside. Now, mind you, we are giving some suction also here so that the blood also, some part of the blood also comes out along with this. So this is one way of taking out. We have many different ways. Other way is called a suction device. There is a tube which we take inside and suck the clot out. And this is what a clot looks like across the stent. And this is from, this patient. So this is a large volume of clot which has gone and which is lodged in the artery. Now we need to understand where this clot arises. Now, because of the high cholesterol or some, I'll come into that, or some other risk factors, there is some cholesterol deposition in our neck arteries, either these vertebral arteries or the carotid system. And the deposition of those cholesterol, we call it plaque, Plaque, plaque. And that happens in the wall of the artery, inside the wall of the artery. So when there is an extra deposition in the wall of the artery, obviously the lumen of the artery will get compromised and the artery will become narrow. Now, along with that narrow thing, some other funny thing also happens. The surface of that, the layer of the cells which are surfacing or which are covering that plaque, they can break, actually. They can break. And they will form an ulcer. And the ulcer means there's a raw area. So if there's a raw area, the platelets in our blood gets activated, which attracts some red blood cells also, and it will form a clot on the surface of the plaque. But there is associated blood flow, which is going from the heart to the brain. So with the flowing blood, which is in contact with the clot tends to dislodge from the surface of the plaque. It goes inside the brain and it lodges into the smaller area. So the larger the clot, the larger arteries will get blocked. If the clot is small, it will run into the distal territory and probably the patient will have a smaller stroke. Now, this is how the clot formation happens inside the artery. Now, not all the clot will form in neck arteries. The clot can form inside the heart itself. So why the clot can form inside the heart? There may be many reasons. There may be a hypercoagulability of the blood. The blood is more sticky, or the patient is a heavy smoker, which makes its blood sticky. There may be some genetic conditions, or there may be some irregular beating of the heart. We call it atrial fibrillations or AFib, which makes the heart to beat in a very feeble manner, and the heart rate will go high. So there will be a lot more stagnation of the blood inside the heart cavity. So when there is stagnation of the blood, there is a more tendency, to form clot inside the cavity of the heart, and with blood flow, that clot can go inside the brain and can cause stroke. So these are the usual areas where the clot can form and the stroke can happen. Now, just compare these two patients. There are two cases in the same in our hospital only. One patient we treated the left side, the case 2, and the case 1. The patient came quite late and he could not be treated by medicine or by thrombectomy. Now, what is the next step? Next step is surgery, open surgery. Now, when there is a large part of the brain is getting affected, the whole area swells up. We call it edematous brain. The brain swells up. It's very similar like when we fall or when we injure our hand or leg, the hand, that part of the limbs becomes swollen for the time being, and then it again goes back to its original position. The same thing, same pathology happens in the brain also. The brain becomes gets it swells up, it becomes swollen, and this swelling causes compression on the surrounding normal brain. So the normal brain, which is in and around that infarcted or the stroke affected area, their viability also becomes at stake, and eventually, because of the compression, the patient's sensorium goes down. So what we have to do, we have to make some space in the brain. So we take out the skull bone, keep it in the laboratory or inside the abdomen of the patient, and that's how we make some space for the brain. But if the patient's the affected area is too large, that itself can kill the patient. One such example, which is really hard to uh, believe that this can happen. Now, what are the risk factors? Now, the stroke is one of such things. Stroke and heart attack, they are modifiable in a large quantity. They are modifiable. So the risk factors, when we can address those risk factors, the chances of getting a stroke or heart attack, because essentially the stroke, heart attack, they are all the same. Only the pathology is same. They are affecting the two different organ systems. So a patient who is having a stroke, they're also in danger of getting a heart attack, or the patient who is having a heart attack or has undergone CABG or coronary stenting are at risk of getting a stroke also. So they should be investigated for the possible problems in their carotid arteries or coronary arteries. Now, smoking. To my mind, smoking and diabetes, these are the two very important risk factors which are modifiable, causes the vast majority of the stroke. And the combination of smoking and diabetes is little. Hypertension, again, can be prevented. But sometimes some patients come and tell me, my blood pressure was high, I was taking medicine, but it has become normal and I've stopped it. So that is the last thing you should be doing, because your blood pressure is normal with medicine. So without medicine, again, it will shoot up and you can have hemorrhagic stroke. High cholesterol. So after 40, and nowadays actually we are seeing a so high percentage of having young stroke, especially with this so much of irregular lifestyles, having junk food, having so much of cigarette smoking. The incidence has gone so high, and irregular lifestyles, having a lot of intake of alcohol without any exercise, physical inactivity has made them at a very high risk of stroke. So cholesterol level is very important, and we should check our cholesterol level, and we should be avoiding all those food items which can increase the cholesterol. Now, irregular heart rhythm, obviously this is a disease and you should go to a cardiologist. There are methods available by pacemaker or some electrophysiology, wherein the heart rate can be corrected, and it can come back to normal. Narrowing of the carotid artery after a certain point of time. Now, in a normal health checkup, we also should include a carotid Doppler study. Which is a very simple examination, and in most of the cases, you can identify whether the patient's carotid arteries are normal or not, and it doesn't include any radiation like CT scan or CT angiogram. And but if the patient is not comfortable with carotid angio, go for an MR scan, go for an MR angiogram after 55 or 50 or 55. Not in all patients, but those who are smokers, who are having hypertension, who are having diabetes, who are having high cholesterol, obviously they are at risk of having a stroke, so they should be checked. Diet and nutrition is a very important factor which all of us, we tend to ignore. Obesity is again a very important modifiable risk factor for stroke, physical inactivity, and oral contraceptives, what I am specially mentioning, especially in women. Although nowadays it's not being used as it was being used in the past. So all these are modifiable factors which can lead to stroke or heart attack. Now, with these so much of problems, the risk factors which are increasing, the world statistics says that in a room, 1 in 4 can be affected by stroke. So that was the World Stroke campaign by the World Stroke Organization, which was there that don't be 1 in 4. That means in 25% chance of having a stroke, which will be there in our country. So we should avoid by avoiding all those risk factors by getting a good lifestyle. So as of now, we have discussed only with the ischemic stroke because that takes a large chunk of the stroke, which is around 85%. In 15% of the stroke, obviously, this is hemorrhagic stroke where there is a bleed inside the brain. And in most cases, again, it happens because of high blood pressure. So the control of blood pressure is very important. Obviously, if the patient is not hypertensive, if the patient is young and the patient is coming with bleed in the brain, that means if the patient is having a hemorrhagic stroke in a non-hypertensive status, then obviously those patients should be investigated more for having any vascular pathologies and should be treated accordingly. So obviously, we should know the signs and symptoms of stroke. And at the end, I would say, if we can understand the signs and symptoms of the stroke and we can, the timely treatment is instituted, then our brain can be saved. And that's why we call time is brain. So I'll stop here and maybe we can discuss because it's already 7:30. We have half an hour to discuss. We can discuss and I'll be glad to answer your questions.
Doctor, in the chat sessions, I have raised some questions.
Okay.
If you can have a look at it, and though most of them possibly you have answered, but I still have some doubts.
Yeah. Chat. Yeah. I can see. Yeah. Okay. I can see only 2 questions.
But in the first one, there are 3 parts.
Okay, fine. So what treatments are available for ischemic and hemorrhagic stroke? So I have discussed the treatment
Correct.
of the ischemic stroke in this discussion, and the hemorrhagic
Yes.
stroke. See, the hemorrhagic stroke, if it's a small hemorrhage, inside the brain, we can treat them with medicine only. But if it's a large bleed and if it's causing some compression in the brain, we have to take that clot out. And that is done by a surgical method with some endoscopic. Nowadays, we do with endoscope. We make a small hole in the skull and we put an endoscope inside and take that clot out. But we need to understand why it has happened. So we need to do an angiogram called DSA, digital subtraction angiogram. We puncture the groin artery. We take the catheter into the carotid system and the vertebral system. We give some dye injection, and we see the movies of how the blood is flowing, whether the arteries are okay, whether the arteries are malformed, like arteriovenous malformation, or there is an aneurysm, which is a swelling of the artery. So
Okay.
once we find those things, we'll have to treat that. And the vast majority, I would say around 95% of these things, we now treat with endovascular surgeries. There is no need to open the skull, and we can cure them all these problem of the arteries. What are the effective methods of improving stroke education in communities? Yes. See, this is a very important, I would say, a big challenge for all of us. And I should not be restricting it only to the medical community, because understanding stroke, and this is not a rocket science, it's very easy to understand, and also we know the risk factors. Only these things, if we can propagate, so all of us together, if we can propagate in the communities by sort of a discussion, by sort of a group discussion in a particular age group, maybe the in an age of more than 50, we can make a small session and discuss what are the signs and symptoms of stroke, and maybe one of the stroke nurses or the stroke physician who can go and discuss and answer. And obviously through some print media, through social media, this should be propagated. So this thing is very important, that all of us should understand that the devastation it can cause because of the stroke. See, the heart attack, why it is so much, the awareness is so high, because there is a fear that the patient is going to die if the patient's heart is not, the coronary arteries are not perfused. But here the patient is not dying. The patient is not dying. So, and the patient initially probably didn't have much pain. So, it happens suddenly. The weakness is happening and it's gradually increasing. And probably that is the reason what we feel that it has not, struck the general population so much, because they are not dying. But they should understand that a patient who is not able to speak, if he's a teacher, or or if someone is not able to use his right hand, if he's a writer, or for that matter, and anything for that matter, if someone is not able to walk, so it's a huge burden for the community. It's a huge burden for the family. So sometimes we see the patient comes to the hospital, because these treatments are not very cheap. It's also, it's quite a substantial amount of money is involved. So, but if you see the amount of money they will be spending throughout the whole life for sustenance, with the rehab, with the medicine, and also the loss of job, it cannot be compared. So I think these are the ways which we can propagate the stroke.
As well, doctor, I feel there is a huge confusion in understanding of the difference between stroke and heart attack. Because
Yes,
I've
so that's,
heard a lot of lay comments,
yeah,
and they're not sure whether it is a stroke or whether it's a heart attack.
exactly. That's why I kept this slide in my first slide, that the stroke is brain attack, heart attack is just heart attack.
Heart attack, okay.
Heart attack. So that's what it is. Now, what role do family dynamics and social support system play in stroke recovery across different cultural groups? So once we treat the patient, so the patient is out of the hospital. They will not be there in the hospital forever. So now they have to go back to their families, and the medicine will go on. They will come back to see their physicians in regular intervals. So what will happen in the families, there will be some sort of a physiotherapy. The support systems will go on in the families, along with the medical medicine for stroke recovery. Because what we see, typically a small stroke takes around 6 to 8 weeks to recover completely with medicine or with proper treatment. But if it's a large stroke, it can take years, or if it may not come back to normal at all. The patient lives with the deficit. So there has to be some sort of a social support system should be developed, so that those patients, nowadays actually a lot of other systems are coming, robotics and assistance, physiotherapy are coming. So, and the occupational therapy has come into play. Like, each particular thing is taken care of. It's not only the broader perspective of moving the hands or the legs, how to adjust each finger, how to write properly, how to paint a picture. So all these things, and the speech therapy, when the patient loses speech completely, then it takes time. It takes a lot of time to come back, because what we see that after a large stroke, the speech and the right hand movement because when the speech and right hand is involved, we know that the left side of the brain got affected, because our speech, our memory, everything is on the left side of the brain if we are right-handed. But if we are left-handed, then the chance may be there that your brain is equally represented on both sides. In that way, you are lucky. So if the right side is affected, the left side will take over. But in a right-handed person with a left dominant brain, the chance is very less that after a large stroke, the patient will recover completely.
Okay.
So, yeah. So what do you mean by stroke ready hospital? Yeah, that's a very important question.
Because I thought every hospital is stroke ready.
No, not at all.
Yeah.
The stroke ready hospital, it's not just a stroke ready hospital. It's the term is there in the literature, means that there is facility in ER, when you go to ER, to check whether the patient is having a stroke or not, immediately doing a CT scan, injecting the tissue plasminogen activator, the medicine, and if required, the patient should be taken to cath lab and go for mechanical thrombectomy. So that is a stroke ready hospital. So you should be, the facilities of IV injection, the mechanical thrombectomy, all these things, and the stroke ICU and the stroke ward. These things should be available to qualify this hospital as a stroke ready hospital in under the medical laws. But unfortunately, very few hospitals are there in Calcutta, and not in Calcutta, actually in all the cities. Very few hospitals are there who are stroke ready hospital. So,
which are those in Calcutta? Any idea, doctor?
yeah, I can tell you. This is I hope this is a private chat. So,
Okay.
see, none of the government hospitals, unfortunately, are stroke ready hospitals. So in the private hospitals, like Institute of Neuroscience is a stroke ready hospital.
Of course.
The Manipal Hospital is a stroke ready hospital. Couple of Manipal hospitals are stroke ready hospitals, and CMRI is a stroke ready hospital, and Apollo is a stroke ready hospital. Other than that, there is no other stroke ready hospital. Everyone claims that they are stroke ready hospital, but once you go, the endpoint becomes same.
Okay.
Doctor, my name is Praveen Bharatiya. Can you hear me?
Sir, yes,
Yeah.
yes.
Okay. I have a question which may not be directly related to treatment or symptoms.
Yeah.
It is about, like, what I really understand is that the most important thing in an event of a stroke is the time factor,
Absolutely.
right? So, okay, it's okay, like if you have somebody in the near vicinity who can help you. But just one thing, sorry. But my question is, like, what happens if somebody is alone at home?
Yes.
And like, how does he manage to survive?
That is very important questions and a very difficult situation, actually, especially in our country, because we do not have any 911 or those sort of system in our country which works efficiently. So what you have to do is that you have to know. Obviously, now the ambulance system is working throughout India, so you can call the ambulance, the emergency ambulance, and if somebody is becoming a big stroke and somebody is becoming unconscious immediately, then obviously there is a very less choice is left actually for him or her. But if he can at least dial the mobile phone, or a phone which you can call an ambulance, or a stroke ready hospital, say like this is the number. Now all these hospitals are giving their numbers. Please call them and tell them, okay, I'm just I think I have a stroke, please come and help me. So They will definitely come and pick them up. But alone is really a problem at old age.
I will I will go to the next step.
Yeah,
Like, I know of cases
yeah,
where I don't know if I'm using the right term or not, but uh, people say that in an event of a uh, thrombosis, or I don't know whether thrombosis is the right, like, like a person had thrombosis and he he died within a minute or something,
yes,
or
possible,
maybe 2 minutes or 3 minutes.
possible.
Now, suppose suppose I have I live alone, okay? And
Okay,
suppose I get a stroke in the night, or
right,
maybe in the daytime, anytime.
yeah,
Now, knowing the condition, the road conditions in metropolises,
yes,
I can be 110% sure that even if I call an ambulance or an emergency service, it will never reach me within 5 minutes or 7 minutes, which is actually the norm in Western countries.
true,
Okay. And suppose I get a stroke, that's the next possibility I'm talking about. Like, I get a stroke and I'm unable to speak because speech is the one system, one symptom of a stroke, according to your that be fast,
yes,
you said. So I'm unable to speak, and I'm unable to express myself verbally, or
yeah,
phone, or pick up the phone and dial.
yeah,
Or maybe the phone is not in the near vicinity.
yeah.
Then what do I do?
This
Do I
is
die?
these are absolute possibilities, particularly when one is staying alone.
Yeah, unfortunately, these are the possibilities. So your first question, like with a thrombosis, can someone die instantly? Yes. So
Uh,
the with ischemic stroke, when the artery is getting blocked, the patient will not die immediately, because this is his or her symptom will be, the deficit, which can be a loss of speech also, But fortunately, the speech does not go all on a sudden. It becomes slurred, and then gradually it goes. So what is the evolution of the stroke? We have to understand. Evolution of the stroke is something like, it takes time to intensify, then it becomes a plateau, and then it becomes better. So until and unless someone is extremely unfortunate, that on the back artery, a huge artery is blocked. We call it a basilar artery. So in a basilar artery stroke, immediately the patient becomes unconscious. So obviously he cannot do anything, but which is less in number. But in the front artery stroke, the carotid arteries, it gives time. It gives time. Someone's hand will be weak, the speech will be slurred. So he or she, if they are little bit kind of aware of the things. And one thing is very important in this context is that I should know whether I am having the risk factors of getting a stroke or not. So once I'm living alone, I should get myself checked thoroughly with these things, so that I have to know my the position, that how much is the risk of my with these risk factors of getting a stroke. So I should form a friends group or a relatives group, something like that, and who can help me at the time of the need, so that you get help immediately. So that is very important. And but the thrombosis, which can kill within minutes, yes. Thrombosis is a kind of a layman's term. So, or clot is a layman's term. But by thrombosis, what we essentially mean is a clot inside the artery. And the term thrombosis got popularity by the thrombosis of the coronary arteries, coronary thrombosis. You know, so brain thrombosis, no one talks about the brain artery thrombosis. Everyone talks about the coronary artery thrombosis. That means suddenly a huge chest pain and the patient dies within no minute. So there is a large clot which got lodged into the coronary artery. The patient gets pain, unconscious, and dies. So that doesn't give much time. But in thrombosis of the brain vessels, it will give you the time. It will give you the time. So the patient will become weak. He will take some time to become weak. His speech will become slurred. It will take some time that, but if someone was sleeping, then you can't do anything. When the patient gets up, he becomes completely aphasic. He cannot move. It becomes very difficult for them even to get down from the bed with one leg or one hand completely not working. So that becomes an unfortunate situation actually.
So basically, we are driving at the point that if that kind of a situation is there, which according to medical specialists like you could be a small percentage, but unfortunately, nobody knows who will be amongst that small group of small percentage people, right?
Absolutely.
So if that happens, then there is no way that I can seek medical help.
No, I'm not telling that. So
No, you can be realistic with us.
yeah,
Because
I'm being realistic. That's why
we are now quite mature.
I'm realistic because that's why I'm telling the prevention part here, so that I should know whether I'm at risk of getting a stroke or not. So if I know that I have a risk, then obviously I will take something to prevent that, or I'll keep a domestic help who will be staying with me for 24 hours. So, but living completely alone with lots of risk factors, morbidities, previous history of some of these sort of issues is not a very good choice.
Is
Okay.
a big risk factor.
Okay. Well, one little thing may I
Hello?
suggest? Yeah. Can you hear me?
Yeah, I can hear you.
Yeah. Could I suggest one little thing which I have seen in Western countries? Like people, especially with old people over there, it is very common that oldies live alone.
Yeah.
So over there, what they do, they get hold of a beeper,
Uh-huh.
and that beeper is available with a locket, which
Yeah.
they can hang around their neck.
Yes.
And the beeper is connected to the central office. There is a central office, and the moment there is a beep, that central office automatically identifies from which number it is coming or from which person it is coming, and it directs that situation to the closest hospital
Yes.
to the caller. So beepers are available here also, but the system is not available.
Absolutely.
So could I suggest and request your doctor community to communicate with the government and the medical associations? You have very powerful medical associations, that this should be introduced as a system for saving lives.
Yes.
And not only for stroke, I'm talking about any medical emergency or any help.
Yes. See, in the Western countries, the situation is completely different, and absolutely correct that you have said, like, if someone cannot press 911, just one simple button in the phone can
Yes, but
press,
yes.
and they will arrive within no minute, within 3 minutes. I was working in UK, and I have seen the system, how they work. Once your kitchen, there's a lot of heat or some smoke is there, within three
Anything.
minutes they will come for help. So, but in India, we as a doctor community or our those groups, our societies, now we are still fighting to make this TPA available in all the hospitals for free, then getting this mechanical thrombectomy uh, approved by the government of India so that the cost comes down. So all this, we are still in a very basic stage. Actually, we are still in
No,
a very
but
basic stage. As far
unfortunately, I have not even heard anybody initiating this particular system.
yeah,
And I, for a long time, I have been wondering because I came across this beeper system back in
yeah,
1975, and it is so unfortunate that India
yeah.
now being presumably the fourth largest economy in the world and so advanced, this little thing to save lives, the medical community has never thought about it
Absolutely.
or never
Praveen,
initiated.
Praveen, Praveen,
Yeah.
I sort of disagree with you. Earlier this year, I bought a Titan watch in Hyderabad, and the Titan watch is coming up with a panic button right in the watch that you press, and it will get you help right away. For instance, if you fall and you hurt yourself and you cannot get up, you can press the button on the watch, and that will send the message exactly as what you're looking for. So
No,
India is pretty sophisticated.
I didn't know about it, but I appreciate. But the downside is that it is available in a Titan watch, which I don't know how much it costs over here. I'm sure that a beeper would, would cost a lot less considering the general economy of this country.
Yeah,
I'm,
that's true because
I'm
Titan
not
watch.
I'm not biased in favor of beeper or against any other. And it is very good that in Hyderabad, if it has come in Hyderabad, it must be available in Mumbai or Kolkata also. But unfortunately, it has not been popularized. This, if it is available.
So there is like nothing such which is available or which is accepted in a general population, and because
Exactly.
see, simple beeping is not enough. It has to be connected with a broader system of communication to the
Whatever
hospitals.
that system
Yeah,
should.
it is not there. It is not there.
No, I know that it is not there. That's the reason I was asking this question, that why has your medical community not popularized it over here?
Yeah, that's
I'm not
obviously
accusing. I'm not
no,
accusing.
on us. Obviously, falls on us, falls all of us, and yeah, let us try that. But with this huge population and the kind of social system we are in, and see, like, if everything is there, that this is there, the stroke ready hospital is there, but reaching time in this heavy traffic still becomes a problem. So the basic understanding that when an ambulance is coming, that we have to make some way, that is itself is not there.
No, but that could not be an argument for not initiating the first step.
No, yes, absolutely not. Absolutely not. So that's a kind of a huge work that we have to do. And it is not only the medical problem, it's a social problem actually.
Yes. Thank you, Doc.
Thank you so much.
Question is done. But yes, at least I got to know a lot of things today. So, anybody else?
Yeah, a lot of us got to know a lot of things. Now, one of the things that has happened is Arun has lost his connectivity. So, doctor, I think the normal practice is Arun gives the final, Thanksgiving kind of thing, which I'm not very comfortable.
Jay, you could do that, or Goduli could do that.
Praveen, I think you are more.
In fact, all of us are very thankful to Doctor.
Yes,
for-
yes.
Thank you so much, sir. Thank you so much that I could speak to you, and all your points are being well taken, and I'll definitely work towards that. Thank you so much.
We are sorry that there could have been a bigger audience for this important session.
Correct.
But the loss is not
Yes.
ours. The loss is of those
Who did not?
friends
Anyway,
of ours who did not join today.
Yeah, recording is available. We will circulate it. Whoever is interested, they can watch.
Yes. We'll look forward to that. Thank you, Doctor.
Right.
Thank you very much, sir. Thank you.
I'm stopping the recording now.
Good night to all of you.
Good night. Good night.
Bye.
Good night. And thank you very much.